Welcome to ePathshala once again. Subject social medicine and community health. We have been discussing all these days about healthcare delivery system. Thanks to the principal investigator, Professor Vidya-mitra, and his team from Aligarh Muslim University. To define, for these tribal communities, according to Article 342 of the Constitution, the scheduled tribes are the tribes or the tribal communities or part of or groups within these tribes and tribal communities which have been declared as such by the President through a public notification. Now, this public notification has come probably because as and when these the tribal populations were discovered in all parts of the country, they were given names because of their separate habits. They were put into this category of scheduled tribes. Why? Because they would need special care in that particular area in terms of proper visitation of health educators, of doctors, of medical care, and of immunization schedules for their children. Most important, coupled or rather programmed with a big health education program, because that information, education, communication is the only line of helpline which is going to bring them back or at least attach them with their umbilical cord to the normal population. Now, what are the features of the scheduled tribes? Now, this is defined by one of the committees known as the local committee. They have a primitive state, the geographical isolation, the distinct culture. They are very shy of contact with the community at large. And obviously, they don't come in contact with another community. There is no communication. They are going to be social and economically backward. Pre-agrarian levels of technology, they don't have any knowledge which we are gaining today. They are stagnant or declining population, extremely low level literacy, substantial level of economy. In fact, they are the ones who literally pick out the leaves and the grains from the ground or from their jungles to grind them, to cook them, and to take them. In fact, in some communities, it has been seen sweet potato or the tuber roots or the ground roots are one of the main subsistence levels of food in their community. And as a result, because of intake of only one nutrient and the minusing of all the other nutrients, they have a lot of nutritional deficiency. And as a result, women are weak when they become pregnant, they deliver, the child is underweight, maybe extremely low body weight, so the child deaths are there, maternal mortality is high, and infant mortality is high. And since they don't permit the entry of a lady health worker or an auxiliary nurse midwife, their situation is extremely precarious. Prevailing state of tribal affairs. They constitute 8.2% of the total population of India. About 635 tribal groups and subgroups, including 75 primitive communities, have been designated as primitive based on pre-agricultural level of technology, low level of literacy, stagnant and diminishing population size. Most important characteristics of this: relative isolation from the mainstream of population, economical and educational backwardness, extreme poverty, dwelling in remote, inaccessible hilly terrain, maintenance of constant touch with the natural environment, and unaffected by the developmental processes undergoing in India. It has now been concluded that these tribes descended from the aboriginal population in India. India is only second to Africa in terms of tribal population. Maximum tribal mass is concentrated in northeast India, highest in Mizoram at 94, followed by central India, highest in Chhattisgarh 31%, and lowest proportion in South India. कितना हुआ किशन को 12वें में सेकंड हाँ हो गया ना अब सेकंड में है ना. This is a map of the tribe distribution in India, and you can find that they are actually scattered all over the country. No part is relatively free from them, but you will find even in the states, they would be in the remotest part of the states which are still very unconnected. And for example, let us take Uttar Pradesh. Uttar Pradesh, mostly they would be available in and around the border areas of Bihar with Nepal or Bhutan. In those areas which are populated with jungle and no roads reaching to them, and even if so, they are encircled and completely isolated population. Now, tribal health culture. Mostly they are forest dwellers. They follow the traditional healthcare and follow the traditional healthcare system. It combines both the herbal and the psychosomatic lines of treatment. Naturally available substances are there. Touch of the magic mysticism. They would rather believe on the Jhalku and in Hindi, as we would say, Jadoo, naturally, and touch of the magic mysticism, then followed by supernatural beliefs of ghosts or witches inhabiting the bodies of women who will then start getting tricks and they will foresee or forego or foretell the future of the sick people in their own community. And these systems have long been prevalent, and in fact, they have now been integrated into the tribal systems of practice of medicine. Unfortunately or fortunately, this Harpuk system, like I mentioned in the previous lectures, it has not actually been incorporated into the indigenous six practices of medicine. But still, they are there and very much to see. And we have to now evaluate how much of it is useful and how much of it is harmful to our tribal people. Most important, faith healing, which can be equated with rapport or confidence building. An interplay of complex social, cultural, educational, economic, and political practices. The treatment of diseases have been closely associated with common beliefs, customs, traditions, values, and practices connected with health. Hence, it is now required to change the health services to conform to health culture of or for optimal utilization of health services by the tribal community. In other words, what we mean to say is that it is high time that those closed roads have to be opened. We have to enter these communities. We have to communicate with them in their language, in their and within the bounds of their understanding, and bring them to be a part of the natural stream of our country. Tribal medicine and healing systems, let us accept what is good, what are the good practices amongst them, and incorporate those good practices so that they feel comfortable when they come into the mainstream of our country. Tribal medicine and healing systems need to be scientifically studied, to be combined with the modern allopathic system. and sufficient knowledge about culture, environment, natural and human resources, skill endowment, and belief systems. In other words, we have to train them to become useful members of the community so that they would be able to walk hand in hand, if not behind, at least with our customs, cultures, and requirements of a normal life, available and affordable for the underprivileged tribal population. Yes, we would have to take care that medicine, foods, and such things which are available normally in our community would be available to them at an affordable price. And maybe we could train the younger growing tribal population to become active and effective members of our community. Then we should study their behavior in health and disease, encompassing the cultural and environmental aspects. And this is all, of course, envisaged to uplift the health status and the health and nutritional status of the tribal population. Whenever we discuss the field of tribal health, it becomes a multifactorial challenge because these multifactorial challenges have multi-pronged approach, will require a multi-pronged approach into when we enter this particular tribal system. And that will include socio-demographic, economic status, education, job opportunities, health status, technology, migration, and then defense. See, because these are the factors. Now, if there are some tribal populations who move from place to place. They are never in one place. Maybe for 2 3 days, they stay there, make food, live there, and then they disappear after some time. So they are just like the gypsies who are found in parts of Europe, England, and they are the migration population. So we have actually in certain areas they could be migrating within their own jungle system. So therefore these systems have to be corrected by constant contact, by constant personal endeavor to gain their confidence by introduction of those technologies which could be acceptable to them so in order to improve the health status, provide job opportunities which would be equal to their understanding and that they could fit into that. So these job opportunities should not be very technically very high. Now, of course, tribal areas have been studied, tribals have been studied, and health problems of these tribal areas have come out in polls. That is, one of their most important is alcoholism. Now, where do they get the alcohol from? It is not from the bottles which are sold in the beautiful marketplaces of our country. This alcohol is the rough natural alcohol which is made by them from either the leaves or the fruits, for example, of the neem tree or of the yellow neem flowers and so they make it from rice, they make it from the root vegetables, but and they cook it in such a way, they have their own habits. They cook it in such a way that it is equivalent to a high alcohol content, and as such, most of them uh, drink. Alcoholism is not alcoholism. Drinking and the use of alcohol is common both among males, the men, the women, and the younger women too, and maybe some of the children who are growing up. Then, of course, they have problems of drinking water and waterborne diseases. Now, drinking water, they don't have a regular source. If there is a well in that area, they will use that well. If they are living in the hilly areas, the the water which comes down the springs and during the rainy season down the hill, that becomes their drinking water. And they probably all those waters are rich in in fact, rich with heavy minerals, and as such, they could be causing harm to the population. Then, of course, the waterborne diseases, they would go for defecation. There is no regular place for defecation, urination, no hand washing, no health educational understanding of what is personal hygiene. As such, diarrhea, dysentery, and they would be treated in their own fashion. So, maybe resulting in higher morbidity, higher mortality. Malaria, I just mentioned a few while ago, malaria is still rampant among the tribal population because wherever they are living, these are closed pockets of cities, which do not permit entry of external people. In or either the sprayers or those people who take the blood samples, who those people who take the medicine. Since none of this is available, malaria is rampant and people die of malaria to an extent. Then, as I said, because of their habits of intermingling, intermarrying amongst their own self, genetic disorders are on the rise. And this is as a result of the traditions which they are following. Then malnutrition, because obviously without any educational, without any understanding of what is nutrition, what is good for their body, and a following age-old traditions as far as feeding is concerned, malnutrition is rampant. And then most important, their living conditions, because of no sound living conditions, they have roughly built huts, built with the material, whatever is available in the uh, jungle or in the islands, wherever they are living. As such, no spray is done. So, as such, they are open to animal bites, suicides, accidents, and there is nobody to help them. The Tribal Health Initiative model was started in 1992 by Dr. Rishi George and Lalita Reddy in Tamil Nadu, based on a three-tier framework of healthcare staff, doctors and health workers, and health auxiliaries. Base hospital acts as the center and administrator of a health system. Then the first phase of the base hospital and the outpatient facility. In fact, I would like to mention here that from a personal experience, I visited the hills of Nilgiri Hills and visited Uti, Kotagiri, and Kunnur. In Kotagiri, we were visiting a doctor who was living and working amongst the tribal population of the jungles of Kotagiri, and we had a very amazing ride, at least 3,000 feet down the hill into the jungle, where he had actually built a small primary health center to cater to the needs of those tribal areas. And we found that there was definitely an improvement as far as acceptance of health services was concerned. But the tribal areas will be tribal areas. So as such, this has to become on the national scale when we are able to contact each and every one of these tribes and bring them and run them in the common stream. Currently, this hospital which we are talking about in Tamil Nadu has 20 beds with stabilization and IUCD is being provided on a voluntary basis. Health workers and tribal women who have studied up to 8th standard and have received at least 1 to 1.5 years of hospital-based residential training in primary and secondary care. And health auxiliaries are the illicit tribal women past childbearing age who function as these first point of contact. Now, this is in fact a very good model because what these doctors have done is they are using people from their own tribal population to educate them to become people of first resource and putting them back in the tribal population so that they would their lectures, their additional help would be more acceptable to them, and at least there would be a line of contact made between the real tribal population and the healthcare innovations of the outside world. So the tribal health programs, so they are basically to promote healthy lifestyles and to promote nutrition, to promote community health services, to give health education, and maternal support services are a must. And tribal welfare programs have also schemes have started in India, and they are the integrated tribal development project by the Ministry of Tribal Affairs provides grants to the state governments to implement these schemes. Programs for the scheduled tribes meant for the socioeconomic development and protection against exploitation. Because if these people go out, they are bound to be made fool of by the normal public who is living on the outskirts of this secluded community. Then there are Jansala programs, joint programs of the Government of India and 5 UN agencies, and for the universalization of primary education among educationally backward communities. There are ashram schools in the tribal sub-plan areas, pre-matric hostels, and post-matric. In fact, I was reading somewhere about that these hostels have been made and complete education is given, and these tribal children who reach the school age, they are shifted to these hostels to become complete and effective members of a normal community. So, in fact, it is expected that either they would learn higher education or they would be able to go back to their community to give some improvement techniques, to give some knowledge of what they have learned in the outside world. And for these boys, for these children, the Department of Social Welfare maintains many hostels and it provides boarding and lodging facilities to these students studying from 5th to the 10th standard and above. So therefore, education is becoming important addition. Then you have the Navchetna scheme, training of unemployed scheduled youth program, which is taken up by the Department of Social Welfare of Government from year 96 to 97. Training is given to them by reputed sector organizations. Then there is books bank scheme. These are professional books for the school children or for the college children, for the scheduled caste and scheduled tribe students who cannot afford expensive education. Then there are, of course, tribal research centers which have been created to conduct studies on these tribal communities, and they import the training orientation programs on the tribal culture to recommend to the weaker communities for inclusion, because by getting them included into the list of scheduled caste and scheduled tribes, they will be actually in a way being reconnected to the mainland population organization, and to publish means whatever methods they can use to give a lifestyle pattern, a history, a picture to the outside world for necessary health, for necessary inclusion, and for necessary education of these tribal and for their upliftment of these tribal communities. But there are always limitations in such health programs because many of them don't come forward. Some of the data is not reliable. Some tribal areas are absolutely unreachable, and even if data is available, it does not corroborate or does not sync with the actual situation in the tribal areas. So therefore, this data, in order to sync the data will have to be collected constantly on a continual basis. And social sciences should enter the field with proper reporting. So the tribal perspectives are changing and they have to be changed, and therefore it is essential to establish NGOs in including tribal representation. So these have to be brought back into the mainstream, because then only proper suggestions will come from these members to help their communities who are in situation. To establish higher educational institutions, need to design and develop flexible and educational curriculum to suit them. They need to design community schools with seasonal flexibility, because often these tribes would live in places which are flooded and they are completely isolated from the mainland. So as such, because especially in the West Bengal area, Andaman Nicobar Islands, in the Odisha, in Chhattisgarh areas, so these are the areas which are totally secluded at times. So therefore, such educational programs should be there to include them with taking care into consideration all these natural performances by our weather. Legislation should be strengthened to abolish inadequate and forceful resettlement, and good policies and schemes should be framed to answer the problem of lacking rehabilitation facilities, and of course more research is essential. And to summarize, NGOs must ideally be established and run by tribes for their true development. There is an urgent need and importance of intervention research in this field. Lack of inclusion in the environmental sanitation and perspectives of other essential stakeholders like tribes, policy planning, implementing authorities, private entities is to be fulfilled. So therefore, more studies, more knowledge, bring them into the mainstream, and give them their rights and freedoms, their reservations to participate in the political system, in fact, and job opportunities, create them in the government sectors according to their capabilities, and give education schemes and bring them into the national health system. With this, I thank you for listening to my